Hello, and thank you for joining the Donut of Destiny. This is a special episode sponsored by Elucid. References to a specific product, process, or service by speakers during this podcast do not constitute or imply an endorsement by the Society of Cardiovascular Computed Tomography. The views and opinions expressed do not necessarily reflect those of the Society of Cardiovascular Computed Tomography. Now, a word from our sponsor. Elucid is on a mission to help physicians prioritize and personalize treatment based on actual disease rather than population-based risk. Their Plaque IQ product is designed to provide physicians with critical information regarding the type and amount of plaque in arteries that can lead to heart attack and stroke. Plaque IQ is the only FDA-cleared CTA algorithm that objectively quantifies plaque morphology validated against ground truth histology. Now onto our episode.
Hello, listeners, and welcome back to another episode of the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas. Okay, so much of the literature over the past decades supporting the role of coronary CT in evaluating atherosclerosis has focused on large cohort and population-based data sets. However, in recent years, much interest and research has focused on bridging these more population-based data to personalized patient-specific medicine. This bridge from population to personalized will be the focus of our discussion today. To lead our conversation will be my esteemed guest, Dr. Amir Ahmadi, a cardiologist from Mount Sinai in New York. Amir, welcome onto the podcast.
Thank you very much, Parveen. It's absolutely a pleasure and honor to be here. I've been having a pleasure of listening to your podcast over the years, and I feel incredibly honored to be part of it today. I look forward to our discussion today. Thank you.
Absolutely, Amir. The honor is mine. Your reputation precedes you in your contributions to cardiovascular medicine, and I do want our listeners to understand the perspective that you're bringing to this conversation. So before we get into the topic at hand, let's learn a bit more about you. What is your role at your current practice, and how did you get involved in cardiac CT?
Well, thank you. It's a great story and a long story. It started with my internship, an intern year in internal medicine, where I had a great privilege of meeting my mentor in radiology, even though I was in internal medicine, Dr. Jonathan Leipzig, that I don't think needs any introduction. Since that time, we started working on databases that were at St. Paul's, Vancouver. We looked at the relationship between risk factors and presence of atherosclerosis. And we saw that even though there is a relationship at the population level, in individual level, risk factors don't necessarily predict one-to-one presence or absence of atherosclerosis in individuals. And that sparked the interest in me to pursue cardiac CT, not necessarily to become a reader, which I did the necessary training for it, but to use it as a modality to understand coronary disease better, to understand how we can predict MI better, and how we can go from what we are currently practicing to a more personalized medicine in treating and preventing coronary artery disease. I did my training in cardiology in Vancouver, and I had a privilege to join Mount Sinai under tutelage of Dr. Jagat Narula in 2015, and did 2 years of advanced imaging and closely worked with him since that time, since actually 2014 in my last year of cardiology fellowship. And for the past 9 or 10 years, I had a very close relationship with both of my mentors academically, Dr. Leipzig as well as Dr. Narula. So that's basically the story. And over the past 7 years or so, as when I was working as an attending cardiologist, my time was split between Vancouver and New York. In New York, I do mostly inpatient cardiology and cardiac intensive care unit at Mount Sinai Morningside in New York. And in Vancouver, I started a clinic called Early Atherosclerosis Clinic, which I do mainly risk stratification based on detection of early atherosclerosis via different modalities of imaging, mainly cardiac CT, but in some cases, calcium scoring or carotid ultrasounds to identify risk and prescribe personalized treatment in terms of LDL reduction and whatnot to the patient. And hopefully the first paper out of that practice will come in the next few months.
Amir, I was going to say that you have stood on the shoulders of the giants in the field, but arguably you are one of the titans in the field now of cardiovascular medicine and how it applies to cardiovascular imaging. Thank you, obviously, for your contributions to the science. I do want to perhaps set a framework for the conversation we're about to have in terms of two different parts. Perhaps we can talk about diagnostics and therapeutics from the perspective of population to personalized medicine. Could you give us an idea from the 10,000 foot level of the current framework of cardiovascular disease prevention and perhaps how some emerging evidence in personalized coronary CTA can help change this paradigm?
Of course. So, as cardiologists, we love to think that our work in terms of preventative cardiology is pretty sophisticated. But when you think about it in clinic, what we do is one of the 5 things. We either reassure a patient, or we tell them to lifestyle modificate, or we start them on some medical therapy, or we send them for further non-invasive testing, or if we are really worried, we send them for invasive testing or revascularize them. The first 3 of those, meaning reassurance, lifestyle modification, or starting on medical therapy for prevention of MI, is usually based on risk factors. The second 2, which is either sending for further non-invasive testing or invasive strategies, are usually based on symptoms. And we are talking about, again, prevention. We are not talking about acute coronary syndrome. So we basically rely on risk factors or symptoms as a gateway to get into cardiovascular prevention. Meaning that if there was a person that was asymptomatic and didn't have risk factors, or the ASCVD risk factor or ASCVD risk estimate of them were showing a low risk score, we would reassure them. Why would they need to see a cardiologist or do any further work? The approach that we have, that I just explained, come from fantastic ideas and data probably about 40, 50 years ago that were focused on population medicine. For example, we know now, everybody knows that if you decide to do a study on 2 populations, one with certain risk factors and one completely bereft of risk factors, the population with risk factor has a higher chance of having a problem, having an MI, having an event. Similarly, if you look at the patient from a population that are symptomatic and compare it to an asymptomatic population, they have a higher risk. So that's why we are focusing on risk factors and symptoms as entry gateway or as screening tool for getting to this game of cardiovascular prevention. The problem is, when we look at the MI standpoint, when I wear my hat as a CICU doctor, and I look at the patient in front of me that just came with their first MI, and I try to find out, could I have predicted or prevented this had I seen this person about a week ago, based on their symptoms a week ago, or their ASCVD score that I would calculate in the office? The answer is not really. And the reason for that is that symptoms are unreliable screening tool, because it's not like everybody with MI starts with stable angina and then will proceed to MI. In fact, only 1/3 of people with coronary disease have stable ischemic disease, and about 2/3, the first presentation is death and MI. There are very interesting studies out there with regards to reliability of risk estimate scores at population level, at MI population level, looking backward to see if they can detect people at risk. One of the studies that I'd like to quote is the Young AMI study, which was published in JACC in 2018, and it showed that amongst people that are less than 50 years of age and present with their first MI, if they were seen just short time before in a clinic with a question of whether or not they had an indication to be on statin, with that time guideline of 2013, more than 70% of them were either on a low risk or a borderline risk. More than 50% of them, 52% of them actually were on the low risk group. So the combination of this symptom versus risk scoring from the MI point of view going backward would fail us to identify majority of patients, or at least half of the patients, that will come with MI. So I was curious about this, and we recently did, over the past 4 years or so, recently presented it in the ESC in 2024, the same question by combining both symptoms and risk factors. And what we saw is that people who presented with MI, consecutive cases of 300 that came to Mount Sinai, Morningside or Mount Sinai CICU, if we saw them just 2 days before their first presentation of MI, 47% of them would not be recommended statin based on guidelines, and 62% of them, 2 days prior to their MI, would never have reported any type of a chest pain or shortness of breath that would be indicative of something going on in the coronaries. I think that's just remarkable.
Yeah, Amir, this is fascinating, and obviously a challenge that many of our cardiovascular medicine specialists encounter across the world. However, many practitioners out there likely, at least to some capacity, follow the consensus-based recommendations for asymptomatic patients based on risk, or symptomatic patients based on exactly that, symptoms and risk, in terms of deciding what sort of next steps to take. For example, when evaluating a patient in terms of risk prior to obtaining, say, coronary calcium CT, it's as though the risk scoring is the gatekeeper to the subsequent diagnostic testing. And similarly, for patients with symptoms, ASCVD risk calculation is often the gatekeeper to determining whether they should go through to reassurance, coronary CT, or invasive cath. Is that an appropriate method of going about things based on what you know now?
Well, I think it used to be when we didn't have a better tool, but now that we can actually think about the pathophysiology, and I will try to explain that in the next few minutes, I think we need to go back to the drawing board. We need to erase what we have currently and rewrite it. But let me explain to you, before I go to that question, what I think is happening here. I don't think the assessment of risk or risk factors or ischemia or symptoms were wrong in a population level. In fact, I do agree that overall high-risk population, if you have 100 patients that are high risk versus 100 patients that are not high risk, the high-risk ones have a higher chance of having an event. I think ischemic ones have a higher chance of having an event. I think symptomatic ones have a higher chance of having an event. The problem is, in a population in the US or Canada or wherever in the world, the whole pie of the low to intermediate risk of non-ischemic and non-symptomatic are just much bigger than a pie of symptomatic, high risk, or ischemic population, that even a smaller piece of that pie will lead to a bigger absolute number. So that's why, from the population standpoint, when you go forward to predict MI, those things are important. But from MI standpoint, to go backward, the mere number that they produce, just because the population of asymptomatic, low risk, and non-ischemic is such bigger population, the numbers are more from those populations. And I think this is the disconnect that I call a MI paradox. And I think the solution to that is that we start thinking about pathophysiology of MI, that why it happens. And it's not a direct relationship between risk factors or symptoms. What it is a direct relationship with atherosclerosis. It's the atherosclerosis that goes through progression, that causes a plaque that is vulnerable to rupture, and it ruptures and it causes MI. So whether or not risk factors cause atherosclerosis? Well, there is definitely a relationship, but it's not a one-to-one relationship. And I'm pretty sure there are many risk factors that we still don't know about, and there are potentially protective factors that we are not aware of. And therefore, that relationship between risk factors and plaque formation is very complicated. That makes the prediction of who has plaque, who doesn't have plaque, especially in the low to intermediate risk, very difficult. And the way to go about this, in my opinion, is to start thinking about detecting plaque in individuals and try to modify the plaque progression and halt the plaque progression in order to stop the event.
So, Amir, you're describing the concepts of identification of coronary atherosclerotic plaque in vivo. And I think this leads naturally then into coronary imaging and maybe specifically coronary CTA. How do you treat coronary CTA in terms of identification of biomarkers in the context of what we're already using in terms of risk stratification? How are you using it to, say, identify patients at risk, or even say lesions at risk for rupture and downstream events?
I think it's a very fantastic question. Many people have said that, and I will reiterate. I think the disease that we want to prevent and we want to treat is a coronary disease, or coronary or cardiovascular disease. It's a vascular disease. So the disease itself is when you have plaque in the walls of the artery. Now let's just focus on the coronaries. While on the coronary arteries. So far, what we've been doing in terms of risk stratification with all the biomarkers that we have, with all the risk estimate goals, is just a guesstimation of what's going on in the coronaries. Now we have the ability to look at it. If you have plaque, the disease process has started. If you don't have plaque, the disease process hasn't started, no matter what your other risk factors are saying. If you reverse engineer from MI and go backward, the MI happens because there was a plaque rupture. And we are talking about the type 1 MI, because there was a plaque rupture or there was a plaque erosion. That happened because the immediate prior step was a plaque progression. Plaque progression happened because there was a plaque to progress at the first place. So the pathophysiology of MI, as we understand it, starts with a plaque, continues with plaque progression. And when we talk about progression, we are not just talking about the luminal stenosis progression, but the progression of morphology, of a lesion level morphology and physiology towards what is prone to rupture, and it ends with rupture. So when something starts with a plaque, ends with a plaque rupture, and the middle part is a plaque progression, it's all about the plaque. Anywhere else that we look is just a guesstimation. And I think that brings this whole issue of screening with a form of plaque imaging to be extremely essential.
I want to get into the specifics of the screening modality, obviously coronary CT or perhaps calcium score CT and coronary CTA. But before we get there, I want to perhaps put the pin in an idea of risk stratification first. And I want to perhaps bring the point and the counterpoint. The claim at present is that imaging biomarkers are going to give us incremental value in identifying potential plaques at risk and therefore patients at risk for developing an MI. So if that's the case, do we even need risk factors if we can just do imaging on all of these patients? Hypothetical. And then the counterpoint would be, isn't risk stratification good enough? Is the incremental value of coronary CT or calcium scoring CT that good to warrant its use?
I think the first question of do we need the risk factors to assess them and to treat them, I think it's a great question. And I think the way that I answer that is that the risk factor will provide us with a situs for treatment, meaning that if I have a understanding of a disease process in somebody's coronary, so if Mr. Smith comes to my clinic and has a CAD-RADS1 CCTA, I know the plaque has begun in his body and his coronaries. And now he has LDL of, let's say, 90. And he has a mild hypertension that he wanted to treat just by lifestyle modification. He has probably blood pressure of just close to 130. And he has a prediabetes that is like 6.2 6.3. Just because I know that atherosclerosis has started in his body, I will use that information to be much more vigilant about his risk factor control, specifically LDL target. And the reason is we have enough evidence to see that somewhere between LDL of 60 to 70, we stop the plaque progression. We have quite nice evidence that if we stop plaque progression, and I think one of the best papers in this, in a concept, is a paper by Dr. Narula and Motoyama in 2015 that shows even if you have high-risk plaque features, but if you have no progression, you're not going to have event. So if I can stop the progression, which I know that it will happen somewhere in between LDL of 50 and 70 in majority of cases, then I have an argument to do medical therapy to reduce the LDL to what I call his personalized target, which is defined by the presence of plaque in coronaries, in order to stop progression, in order to reduce the chance of event. Same person, if I didn't have that information, and their ASCVD would have been 3.6%, the guidelines suggest me not to treat. If he has a twin brother with a completely normal coronaries, I would do a different approach. I would be like, yes, it's good that you go for walks every day and have a Mediterranean diet. And as long as your numbers are not too extremes, I'd be okay with that. And I think these two individuals, even though the risk factors could be the same, could be very different, because what the risk factor did to the body in one case was to cause atherosclerosis, and in the other case, not yet. So we start with atherosclerosis to come up with a personalized target, but we use the risk factors as the treatment targets to treat the patients with. We see what we can fix in that person that we think contributed to that atherosclerosis.
Amir, super interesting and very representative example, or I guess set of twin examples there. And underlying that is the, I guess, implication that we are taking the identification of plaque by CT, and perhaps more specifically, vulnerable or high risk plaque by CT, as ground truth. Is that accurate? Is that reliable? Can CT truly identify these culprit lesion plaques that are more prone to rupture than others, say, quote, more stable plaques?
I think we are in the process of learning about this. I don't think we are there yet to claim that we can, with 100% certainty, identify those. And I think what I've learned over the years from just researching this area and talking to mentors and a lot of key opinion leaders here is that we may need to redefine the concept on CT. The concept started, as far as I can tell, in 2007 with that seminal paper by Dr. Narula and Motoyama, and then in 2009 that it shows that the two feature positive plaques are predictive of events. But I think where we are now in the concept is that these things are not binary, meaning it's not just the presence or absence of a couple of features that will tell us about the vulnerable plaque. So it's quantitative. We know from histology that presence of necrotic core matters. We know from histology that the volume of necrotic core, which direction of plaque it went to, if it's coming closer to the surface versus if it's causing just a positive remodeling, matters. We also know that this whole concept is very dynamic, meaning that our medical treatments and therapy will change the value of the plaque to the more stable plaque, whereas the natural progression is probably going more towards a rupture. So there is a whole spectrum that I say on one end, there is a stability of the plaque. In the other extreme, there is a plaque that is rupture. And somewhere in the middle, there is this whole concept of a high-risk plaque. And there is no stability in one point in the spectrum. I think as time goes by, depending on how aggressive the medical therapies and whatnot, and the natural progression, we are moving along this spectrum. So it is a lesion level concept, it's a dynamic concept, and it's a quantitative concept. And I don't think it's just the morphology. I think it's the morphology and a lesion level physiology. We've learned from the work of Dr. Samadi in a post-FAME2 analysis in invasive literature that if you have a high wall shear stress proximal to a FFR positive lesion compared to a non-high wall shear stress, a normal or low wall shear stress proximal to a lesion, the ones with high shear stress have much higher likelihood of having an MI. And all of these lesions are FFR positive. So meaning that the presence of that shear stress on a point that the plaque is vulnerable, perhaps because of necrotic core growth in direction of the surface that makes the fibrous cap thin and vulnerable, presence of shear stress there causes a rupture or makes the plaque prone to rupture. We also know that, for example, from the MRLA2 data, that the delta FFR across one lesion is probably the best predictor in that study of the future event. So both of these pieces of information will tell us that the lesion level physiology is important. We know from a lot of histology papers and a lot of post-analysis of major trials, such as Scott Hart, that the lesion level morphology is important. And I think the marriage of these two things can define us this concept of high-risk plaque in much more granular way. And to me, it's not about whether or not this plaque is going to necessarily rupture or not. I think it's a risk estimation of, am I safe in this particular lesion in the proximal RCA that I'm seeing with all these lesion features, morphology and physiology, to just leave it on aggressive medical therapy? Or do I think I should think about revascularization given what I see? And I think this is probably a $100 million question that we need to find out in the next few years.
Amir, as a radiologist, I love the concept that there is grayscale and not just a binary black and white component to understanding the complexities of these imaging biomarkers that we're seeing, both in the plaque and the non-invasive physiology space. And I think you've set us up really nicely to springboard from the diagnostic into the therapeutic component of our conversation now. You had mentioned medical therapy as a means of modifying risk factors through the lens of imaging biomarkers beforehand. So let's flesh that idea out a little bit more. Could you talk perhaps about the future potential of medical therapy in coronary artery disease from how CT may be influencing its development?
100%. I think that's a very important question, and thank you for asking that. So currently, we have this blanket statement of optimal medical therapy, which means that we are going to have a certain target for LDL depending on risk, whether the person is in the primary prevention or secondary prevention. We have very much of a gray zone with regards to DAPT or aspirin use. We do have trials that have shown the evidence for anti-inflammatory treatments such as colchicine in setting of coronary artery disease, but it's not very widely used at the moment. So I think what we can learn in the next few years in CT is that depending on the overall plaque burden and also individual plaque features, we can start the idea of targeting individual LDL targets. We can start testing the idea of who would need DAPT or not, and who would need anti-inflammatory therapy or not. And if they have other risk factors such as obesity and diabetes, whether or not medications like SGLT2 inhibitors or GLP-1 agonists will be helpful. I think this atherosclerosis-based treatment, medical treatment, based on both overall plaque burden and individual plaque features will be subject of many studies. One of these trials that is ongoing right now, Transform trial, I think is a brilliant start to this concept, and it would be a proof of concept to show that plaque-based treatment is a step towards personalized and precision medicine. But I think that will open the door for much more trials in future that will further optimize this approach. And I do really think that when we talk about personalized medicine, the way that I see it, or precision medicine, is that the person, depending on the biomarkers that we find, not just on imaging, but overall biomarkers, both risk factors and imaging and everything else that we can get, be on the amount of medications that is necessary for the disease process to halt or reverse, and not less and not more. And I think the actual optimum amount part is very important. And I think throughout the next few years of studies that are based on imaging, we can get a much better understanding of how this can contribute. The other thing that I didn't mention is a delta of plaque change over time. So I think serial imaging at least 1 or 2 times is needed to ensure that the person is responding to the treatment and the overall plaque is going towards stabilization and not further progression.
Amir, you read my mind in terms of the next question I wanted to ask you, which is a bit speculative in that in the way that we serially evaluate the lipid profiles of our patients in whom we are using lipid modification therapy, do you suspect we'll be doing serial coronary imaging in the future to evaluate for plaque regression?
I can see a future like that, not in a sense that you do it every year. I don't have the answer what's the correct time interval at the moment. In my clinical practice, if I have other indications, I like to do them every 4 to 5 years on people that didn't really develop their symptoms to ensure the treatment that we are giving the patient actually works. And the way that we judge that, and again, like this is a very new field, so we need much more data to actually establish the field. But the way that I think about it is that overall plaque burden should not increase significantly. The non-calcified plaque burden should potentially decrease, and the calcified plaque burden should increase. And on an individual level, what we probably should see, individual lesion level, is a decrease in size of a necrotic core, decrease in the size of the overall non-calcified plaque, and increase in size of a calcified cap or overall calcified component of a plaque. And I think even if I see that once per patient that they're in the right direction, I don't need to reimage them every few years further. But I do think that you at least need one more time of imaging after initiation of therapy.
Fantastic. Amir, thus far we've kind of been focusing on medical therapy for coronary atherosclerosis, but I do want to bring in ideas behind revascularization for, I'm reluctant to say control of atherosclerosis. Maybe I should flesh this out a little bit further. There's a very strong role for lipid modification therapy and other surrogates in reducing the downstream risk of an adverse cardiovascular event. There's quite a bit of controversy over whether revascularization has a similar role in reducing downstream events. Beyond symptom control alone, could you talk to us about how revascularization plays into preventing downstream events and perhaps if CT plays a role in this?
100%. And again, one other fantastic question. I think we need to go a little bit to the literature that we have. We have few landmark trials, Courage, Barry 2D, Ischemia, and others, that have shown that on surface at least, that revascularization in the setting of stable ischemic heart disease is great for symptom reduction, but there is not a clear signal for MI. When you look at the further detail on these trials, especially I'm talking about ischemia, there is actually a spontaneous MI reduction. There's about 52% relative risk reduction of spontaneous MI in the revascularization arm. And in a subsequent paper, the authors published that that type of an MI reduction or a spontaneous MI was associated with cardiovascular death. Unfortunately, as far as I know, there is no EF or ejection fraction post-MI in a spontaneous MI that they had and a periprocedural MI. The reason that they had a overall net zero benefit on MI reduction was that this spontaneous MI reduction was counterbalanced by the periprocedural MI. As a person that works in CCU, for most part, I take not having a spontaneous MI any day of the week over a periprocedural troponin rise. Even though I completely agree, and I'm aware of the literature, that there is a risk with periprocedural MI, and not all of them are trivial. But I think most of cardiologists would agree that if you have a 90% LAD, if that 90% goes down and there is a spontaneous MI, that person is having a very difficult time. And quite a bit of EF is going to be reduced, quite a bit of myocardium is at risk and whatnot. And that's not necessarily the case with periprocedural troponin rise. So then what's the solution? The solution, in my opinion, is that we be more careful in selecting lesions that we are selecting for revascularization in order to get the benefit for the MI reduction, but not exposing all the lesions that don't have a potential risk for MI to a potential risk of periprocedural MI. So being a little bit more precise in terms of the lesion selection for treatment with revascularization, I think is the overall direction that we need to go. So that direction was used in FAME-1 trial. So what FAME-1 taught us is that if you revascularize 2/3 of lesions that you're supposed to revascularize otherwise by a help of FFR, and you defer the FFR negative ones to medical therapy, your outcomes is overall better than if you revascularize all the lesions. So the benefit of FAME-1 trial was not in revascularizing the FFR positive lesions. The actual rate of MI in FFR positive lesions that was revascularized and the overall lesions that were revascularized in the angiography guided arm was the same. The difference in the overall strategy came from the fact that the FFR negatives, I think there were 513 of them, they only caused one MI over the course of 2 years of the FAME-1 publication. So it was a safe deferral of lesions that didn't really need to be revascularized because they weren't at a risk of high risk of MI, that led to a decrease in periprocedural troponin rise and MI that overall caused the strategy of FFR to be winning strategy. Now, take this concept and apply it to what we know now. Now we have much better tools. We have a potential to identify physiology. We have a potential to identify morphology. We have quite a bit of risk estimation and scoring that is under development that can tell us whether a lesion is going to be safe or not. And if we apply that strategy of lesion level high-risk features on the morphology side, plus lesion level physiological measures such as delta FFR, such as potential wall shear stress and whatnot, we have a much better way of identifying lesions that are at risk and potentially can get better with revascularization.
Well, Amir, I think you've outlined what could be a very elegant prospective study in whether or not we can demonstrate a difference of revascularization of judiciously selected lesions relative to those based on our current standard of care. And the judicious selection would come from some of the more modern quantitative evaluations of coronary atherosclerotic plaque we have either via non-invasive or invasive imaging. Is there anything to date that we can either rely on for the precursor to this type of study, or is there anything ongoing at present that you're familiar with?
I mean, I think the thought about this has been started, and we had the very interesting PREVENT trial that was presented that was basically revascularization based on morphology alone. But as far as I'm aware, a non-invasive strategy to guide us with both morphology and physiology to revascularize has not been undertaken. And I agree with you. I think this is a trial that would be extremely interesting. The other thing that I wanted to add is for symptoms alone. Many times in clinical practice, we identify patients that have ischemia. We send them for revascularization. They identify a lesion. They open it up. They come back. We are like, so how are you doing? And at the first, they may be shy, but they report to you that they're not feeling that better. And I do think, again, this goes back to the concept of how are we guiding our revascularization? I think traditionally and historically, we learn to guide revascularization based on an information that is a surrogate for myocardial ischemia. But let's not forget that revascularization, and I'm talking about PCI, not CABG, is a lesion level strategy. So we can have lesion level information to guide that. And nobody better than Carlos Colette pointed this out in multiple publications in JACC in 2019 and a recent publication of PPG, that, for example, if you have the PPG that is more than 0.65, and for those of our listeners that are not familiar with the concept, is basically a pullback gradient. It ranges between 0 to 1, and the closer to 1 that you have, it's basically relationship with FFR. Your FFR drop closer to PPG of 1 is because of a focal lesion, and away from 1 and closer to 0 is more of a diffuse process. So if we have ischemia due to a diffuse process in the vessel, or because of a combination of a diffuse epicardial coronary process and a microvascular process, putting a stent in a calcified lesion that is, let's say, 70% in the middle of that vessel, probably not going to prevent any MI and probably not going to help that much with symptoms. On the other side, if you have a lesion that has a PPG closer to 1, a delta FFR that is significant, and the overall curve of FFR has a sharp drop across that lesion and otherwise is not showing a diffuse process, opening that lesion has a potential for much better symptom relief. So it's not only these parameters that we are talking about that we can get from non-invasive imaging now with CT scan, not only help us potentially go to the revascularization for MI prevention, but for a improvement chance of success of symptom relief as well.
Amir, I want to start merging these concepts now of population and personalized medicine, of diagnostic and therapeutic approaches for coronary atherosclerosis, but I do want to make note of a lot of different concepts that we've touched on thus far in the conversation. We've talked about the minutia of lipidology and lipid profile assessments, of the variety of different risk factors that we're using when initially determining what direction to take our patients in terms of management, the innumerable seeming quantitative metrics that we can assess from coronary plaque evaluation on coronary CT, low attenuation plaque volume, total plaque volume, etc., presence or absence of other vulnerability features, the nuances of non-invasive and invasive physiology with FFR, IFR, FFRCT, wall shear stress, and the multitude of additional points you brought up in more emerging concepts of, say, virtual or true pullbacks. That's a lot of different metrics that perhaps a small cohort of clinicians is going to be able to utilize to determine what the next best steps for patients are, perhaps an overwhelming amount of metrics. Do you envision any tools in the future, perhaps even artificial intelligence-based tools that can help synthesize the variety of different metrics we have in evaluating this complex disease process to guide next steps?
Fantastic question again, Praveen. I think yes. The short answer is yes. I think what I described to you is the different ingredients that are going to go to this, let's say, salad that we want to make. And, with the help of artificial intelligence, with the help of both retrospective and prospective risk estimate or risk prediction trials or studies, and with the RCTs that we're going to do in the next few years, I do think that artificial intelligence and softwares can put all of these things together and give us an overall risk estimate on a lesion level, on a vessel level, and a patient level. And not only that, I think we can also begin maybe in the next few years again with studies and more of machine learning and deep learning, be able to predict the dynamicity of these plaques with treatment and over time. I'd like to talk about the interesting concept that we just wrote for editorial in JACC Imaging that hopefully will be published in the next 1 or 2 weeks. When I talked about the spectrum of plaque going from stable plaque to an MI and high risk being somewhere in the middle of it, whenever we detect as physicians a plaque in a patient's artery, we are detecting it somewhere in that spectrum. We want to push the plaque towards the stable part of the spectrum. The natural progression is probably going towards the rupture part, or the event part. There's a time component here. The time to stabilization we call for the lesion to be stabilized. The time to event is the time that the natural progression wants to have to event. We potentially in future can predict these times at the time zero, because we can train these AI models and whatnot with thousands and thousands of cases. And if the time to stabilization is shorter than the time to event conceptually, then medical therapy is safe for that person. If the time to stabilization is longer than the potential time to rupture conceptually, then potentially you need revascularization or much more aggressive medical therapy. So I agree with you that it's overwhelming amount of information, but I think there is a possible way with the use of AI and use of these softwares that are being developed, such as the company that I'm consulting for, Elucid Software, that we amalgamate and be able to do a lesion-based and vessel-based and a patient-based risk prediction at the end.
Amir, I am both excited and terrified at the prospects of these types of tools being available in the future because, gosh, it is overwhelming, but at the same time, it could totally shift the paradigm by which we diagnose and treat this disease that still affects millions of people every single year across the world. So super compelling stuff. And with that, I want to come to the close of our conversation and ask if you have any concluding thoughts.
Thank you. I do think it's complex, but I think it can be simplified. And one of the ways to simplification of this is to detect early and to start thinking about screening. Because if we detect plaque early, it's just much easier to treat the plaque. We don't have to go through all these steps and whatnot. And I think we need to start thinking about how to use AI to reliably detect at a population level and have an algorithm as to how to treat it. I think the moment that the plaque is detected, we need to start thinking about how to stop its progression. We need to shift that secondary prevention mentality that we take the patient and the risk factor much more seriously after the first MI to the point of detection of early atherosclerosis. And I think if we do that, the problem would be much, much, much simpler to deal with.
Well, hopeful thoughts there at the end that such complex components of evaluation of this disease can be utilized to simplify our approach. And I really appreciate that. Also, super, super appreciative of the time and your expertise that you've dedicated to us on the podcast today. I know our listeners are going to absolutely love the content that they had here. And we only had this much time. I feel like, we could really just discuss this for days at a time. But I do want to bring our conversation to a close. Amir, thanks so much again for coming on and chatting with me.
Praveen, it was an absolute pleasure, honor, and I'm so glad that we had this conversation. I thank you so much for your very, very thoughtful questions and the way that you not only moderate this one, but all the podcasts of Donut of Destiny. I thoroughly enjoyed it over the years. Thank you very, very much.
Amir, appreciate it. Once again, our listeners, that was Dr. Amir Ahmadi, who provided such an important and interesting perspective on hopefully the future of personalized cardiovascular medicine. If you like what you hear from us on the podcast, please remember to rate, review, and subscribe to us. That helps other listeners out there find interesting content like this. Once again, this is the Donut of Destiny. Cheers.